Hello everyone. Today I would like to introduce septic shock. How can it be and what can we do? I'm Su Rongpeng, Chief Physician of Critical Care Medicine of Fujian Provincial Hospital. Firstly, we would like to see a short video to give you some preview of sepsis and septic shock.
The medical team in this intensive care unit at Mayo Clinic is on high alert 24/7, watching for signs of sepsis.
Sepsis is a potentially life-threatening complication related to an infection.
Dr. Kenan Ramar says every year, close to 3/4 people in the U.S. develop a septic reaction. It happens when an infection prompts the immune system to kick into overdrive, causing problems such as kidney failure, liver failure, severe drops in blood pressure, and even death.
It becomes very important that this is recognized early.
That's because the death rate can be very high, up to 75% for people who develop sepsis at home, and up to 25% for those who get it in the hospital.
It's almost similar to treating a heart attack or a stroke, where you have a very short window.
That window is 6 hours. Dr. Ramar's team uses what are called sepsis sniffers, technology that monitors things like fever, heart rate, and blood pressure, and alerts the medical team when a patient's in danger.
Okay, I think let's go ahead and activate the sepsis response team.
We have a patient in room number 20. We want to activate the SIT.
If blood tests confirm that's true, the septic response team launches into action.
It's a big multidisciplinary approach to do this, and so all members of the ICU team are actively involved to get this aggressive resuscitation going and to get all things done within that 6-hour window period. Let's get the central line ready.
We did give a dose down in ED, so continue with that.
We follow what we call as the surviving sepsis resuscitation guidelines.
Methods of best practice developed by the Society of Critical Care Medicine to ensure the best possible treatment for patients.
If the necessary things are done, then the mortality drops down dramatically.
Sniffing out sepsis and saving lives. For Mayo Clinic News Network, I'm Vivian Williams.
From this video, we can see that sepsis is a very severe condition and has a very high mortality. There are very little time left for us physicians to take action to control it, so it's very important to identify sepsis as early as possible. This is today's content. We will involve introduction, definition, causes, pathophysiology, diagnosis, treatment, and management, and epidemiology. 1. Introduction. Let us watch a short video to give you an introduction about shock.
Shock, also called circulatory shock, is a life-threatening clinical state characterized by body-wide deficiency of blood supply, causing oxygen deprivation, buildup of waste products, and eventual organ failure if untreated. Shock may have different causes, and hence its classification into different types. Hypovolemic, or low-volume shock, happens when the circulatory blood volume is severely reduced. This can be caused by external blood loss, such as after an injury, internal blood loss, such as that results from a ruptured blood vessel, ruptured ectopic pregnancy, pancreatitis, or fluid loss from major burns, excessive vomiting, diarrhea, or urination. Cardiogenic shock occurs when the heart fails to pump sufficiently. This can result from a sudden heart attack or an end-stage development in various heart conditions. Obstructive shock is caused by an obstruction of blood flow in a major circulatory circuit. Distributive shock results from excessive dilation of blood vessels, or vasodilation, which decreases blood pressures. Distribution shock can have different causes, the most common being sepsis, anaphylaxis, and damage to the central nervous system. In sepsis, the immune system is overwhelmed by an infection that gets out of control and responds with a systemic cytokine release that causes vasodilation and fluid leakage from capillaries. In anaphylaxis, the immune system overreacts to an allergen, releasing massive amounts of histamine, which has similar effects to cytokines. Peanut allergy is a common cause of anaphylaxis. Neurogenic shock typically occurs as a result of a spinal cord injury. As the autonomic nervous system is damaged, the sympathetic tone that normally keeps blood vessels constricted is lost, causing vasodilation and hypotension. Common symptoms of shock include low blood pressures and signs of organ damage, such as confusion, reduced urine output, and cold, sweaty, mottled, or bluish skin. Although distributive shocks due to sepsis or anaphylaxis may initially produce warm or flushed skin. This is because the infection in sepsis usually comes with fever, and the allergic reaction in anaphylaxis is accompanied by hives. Distributive shocks may also differ from other types of shock by having, at least initially, normal or high cardiac output. As the body tries to compensate for hypotension, fast heart rates and rapid breathing may be observed. Diagnosis may also be assisted by blood tests for blood lactate levels. This is because in the absence of oxygen, the body switches to an alternative way of producing cellular energy, called anaerobic metabolism, in which glucose is broken down only partially, producing lactic acid. Blood tests may also indicate signs of organ damage, or infection in case of sepsis. Shock is a medical emergency and requires immediate treatments, which aim to increase blood pressures and treat the underlying cause.
Septic shock is a distributive shock among the 4 kinds of shock. It is the potentially fatal medical condition that occurs when sepsis, which is organ injury or damage in response to infection, leads to dangerous low blood pressure and abnormalities in cellular metabolism. 2. Definition. Before we get into septic shock, we should know the definition of sepsis. Sepsis is a potentially life-threatening condition caused by the body's response to an infection. Our body normally releases chemicals into the bloodstream to fight an infection. Sepsis occurs when the body's response to these chemicals is out of balance, triggering changes that can damage multiple organ systems. If sepsis progresses to septic shock, blood pressure drops dramatically. This may lead to death. And then, what is the definition of septic shock? According to Sepsis 3 definition, septic shock is the subset of sepsis in which particularly profound circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than with sepsis alone. And it requires a vessel pressure to maintain a mean arterial pressure of 65 mm mercury or greater and serum lactate level greater than 2 mmol per liter in the absence of hypovolemia. It refers to distributive shock due to sepsis as the result of infections. Most of these kinds of patients will be taken care of in intensive care units, and the mortality rate is about 35 to 50%. That's very high. Then, what is the causes of septic shock? It is the result of systemic response to infections or multiple infectious causes. It can be caused by bacteria and also maybe fungi, viruses, or parasites. It most commonly happens in lungs, brains, urinary tract, skin, abdominal organs. The upper figure shows the organs that get involved in the process of septic shock. It causes multiple organ dysfunction syndromes and death. Okay, let's see some common causes of septic shock. The appendicitis is inflammation of the appendix. This is an acutely inflamed and enlarged appendix, sliced lengthwise. Pneumonia is an inflammatory condition of lungs affecting primarily the small air sacs known as alveoli. This is the chest X-rays of pneumonia caused by influenza and hemophilus influenza and petrite consolidations, mainly in the right upper lobe, like arrows shows. Pancreatitis is a condition characterized by inflammation of the pancreas. This is the pancreas and the surrounding organs. Severe acute pancreatitis is a common source of multiple organ dysfunction syndrome. Bacteremia is the presence of bacteria in the blood. Blood is normally a sterile environment, so the detection of bacteria in the blood is always abnormal. It is distinct from sepsis, which is the host response to the bacteria. Diverticulitis, specifically colonic diverticulitis, is a gastrointestinal disease characterized by the inflammation of abnormal punctures, sections of large bowels, sigmoid colons showing multiple punctures. This is a picture of massage. We call it methicillin-resistant Staphylococcus aureus. It refers to a group of gram-positive bacteria that is genetically distinct from other strains of the Staphylococcus aureus. MASA is responsible for several difficult-to-treat infections in humans. This is a scanning electrons micrograph of human neutrophils ingesting MASA. 4. Pathophysiology. The pathophysiology of septic shock has not been entirely cleared. It is an immune and copulation response to an infection and includes prompt inflammatory or anti-inflammatory process, like this picture shows. And the sepsis can also activate blood coagulation and also cause disorder of coagulation. And the endotoxins producing gram-negative bacteria, gram-positive bacteria, and fungal infections is the main common cause of septic shock. And the fungal infections has been rising in recent years. And toxins produced by pathogens cause an immune response. Gram-positive toxins like azotoxins or enterotoxins divided into type 1, type 2, and type 3. This figure shows that azotoxins are secreted by bacterial cells. Clostridium botulinum, for example, and are toxic to somatic cells. Somatic cells have antibodies on the cell surface to target azotoxins and bind to them, preventing the invasion of the somatic cells. The binding of the azotoxins and antibodies forms an antigen-antibody interaction, and the azotoxins are targeted for destruction by the immune system. If this interaction does not happen, the azotoxins bind to the azotoxin receptors that are on the cell surface and causes death of the host cell by inhibiting protein synthesis. Gram-negative toxins, we call it LPS. It is an endotoxins which are bacterial membranes lipopolysaccharides. Lipopolysaccharides, LPS, also known as lipoglycans and endotoxins, are large molecules consisting of lipid and polysaccharides. They are found in the outer membranes of gram-negative bacteria. In gram-negative sepsis, free LPS attaches to a circulating LPS binding protein. The complex then binds to CD14 receptor on the neutrophils and triggers innate immune system reactions and inflammation. And the production of anti-inflammatory substances causes concentrated anti-inflammatory response syndrome. We call it CAS. Inflammatory and CAS are responsible for the cause of sepsis. We call it MAS. And at high levels of LPS, the syndrome of septic shock supervenes. The same cytokines and the secondary mediators, now at high levels, results in systemic vasodilation and cause hypertension, diminished myocardial contractility, and widespread endothelial injury. Activation causing systemic leukocyte adhesion and diffuse alveolar capillary damage in the lung, and the activation of the coagulation systems accumulating in the disseminated intravascular coagulations with ensured DIC. And finally, multiple organ dysfunction syndrome occurs. Septic shock may be defined as sepsis-induced low blood pressure that persists despite treatment with intravenous fluid. And the low blood pressure reduces tissue perfusion pressure, causing tissue hypoxia that is characteristics of shock. And cytokine released in a large-scale inflammatory response results in massive vasodilation, increased capillary permeability, and decrease systemic vascular resistance, and the low blood pressure. And finally, in an attempt to offset decreases blood pressure, ventricular dilatation and myocardial dysfunction occurs. Let's see a short video to explain the process of septic shock.
Septic shock is a very serious condition. About half the patients who have septic shock will die within the first month of their diagnosis. But what is septic shock? Well, let's break down the two words. Septic comes from the old Latin term meaning rotten, and the word shock, of course, means decreased tissue oxygenation and low blood pressure. So combined, it's decreased tissue oxygenation caused by something that is rotten. Now, this rotten thing is an infection, infective material that causes some sort of inflammation. So it's infective material that causes decreased oxygenation of tissues. So how does infective material do that? Well, let's take a look at a blood vessel. And of course, the blood is used to deliver oxygen to tissues. So here are some red blood cells, and I'll put some tissues right here. So these little boxes represent cells. And so these red blood cells are supposed to transfer oxygen, this little purple substance right here, to these cells. Delivery of oxygen to the tissues. Now let's say there's some sort of infective material in the bloodstream. White blood cells will encounter this infective material, whether it's a bacteria, virus, or a fungal infection that's in the bloodstream. So now your blood vessels are like pipes, septic pipes, containing this sewage, this unclean material. It's no longer sterile. So these white blood cells, their job is to find this and clean it up. And of course, when white blood cells encounter this infective material, they activate. When they activate, there are several things these white blood cells do. First, they're going to call on other white blood cells to come and check this out. Because the idea is you want to recruit as many white blood cells to wherever this infective material is so you can eradicate it. So first, white blood cells recruit their buddies. Now here comes a major point. This infective material is normally not in the bloodstream. In fact, it's usually out here in the interstitial tissue. So usually white blood cells have to get into the interstitial tissue and eliminate the threat. Now white blood cells do that by releasing molecules such as nitrous oxide. The molecules that are released interact with the blood vessels and cause the blood vessels to do a couple things. First of all, blood vessels will dilate, or in other words, the diameter of the blood vessel will increase in size. So let me go ahead and erase some of this so we can show the dilation of the blood vessel. And so let's make this dotted, showing that it was this size, and now blood vessel diameter increases. So we've increased from this size to a little bit larger. This causes a localized decrease in vascular resistance, systemic vascular resistance. The blood, all of the blood contents, have more space to move around, and there's less resistance that they're bumping up against because of this widened diameter of the blood vessel. So there's increased diameter of the vascular space. Now, of course, this makes sense if this is happening locally. Blood slows down in an area where there is an infection. Because remember, the immune system usually encounters infected material in the peripheral tissues. To be able to get into the peripheral tissues, white blood cells need to make the blood vessels leaky. And so that's the second thing that's happening here. The increased diameter and increased permeability, or leakiness, of the blood vessels. Now here is actually the cause of shock. You have this infective material in the blood vessels all throughout the body. And so this happens everywhere. Systemic vascular dilation, or vasodilation. And so this decrease in vascular resistance causes a drop in blood pressure. Because remember, vascular resistance and cardiac output equals blood pressure. So a large drop in this causes a large decrease in pressure. But also they have low tissue perfusion, because the equation for tissue perfusion is really the same. Cardiac output and systemic vascular resistance contribute to tissue perfusion. But let me show you something else that's causing low oxygenation of the tissues, low tissue perfusion. You've got these cells that are receiving oxygen from red blood cells. Now with the increased leakiness, fluid will get into the tissues. And so you have all this fluid build up in the tissues, and this makes it really difficult for oxygen to get to the cells it needs to. It has to diffuse through all this fluid. And so these cells become starved of oxygen. And so this is primarily what causes shock. Now there's a third thing that happens when these white blood cells encounter this infective material. They want to destroy it, right? If you've got bacteria or virus or fungus, that's the job of the white blood cells, to destroy this infective material. These white blood cells release lytic enzymes and reactive oxygen species that cause damage to destroy this pathogen. But again, this is happening everywhere. So not only do you damage the pathogens, but you'll end up damaging the blood vessels as well. So that's number 3. You have damage of blood vessels. Now remember, this is happening everywhere, and because of that, serious complications can occur. First of all, when blood vessels get damaged, there are things called coagulation factors in the blood, and I'm going to make them this little lavender color. They're a protein that help cause clotting. So when blood vessels get ruptured, you'd want to create a clot to patch this up, so that blood doesn't spill into the extravascular space outside of the blood vessel. Now again, this is happening to blood vessels everywhere in the body. I cannot emphasize that enough. So what ends up happening is these coagulation factors end up getting used up. They're trying to patch up all these blood vessels, so clots are forming everywhere. And some of these clots actually break off into the bloodstream. So an interesting thing happens. There's coagulation that's happening in the vascular system, but the coagulation can't keep up with the breakage of blood vessels. So sooner or later, blood is spilling out of the blood vessels. This weird state of coagulation in the blood vessels with simultaneous bleeding is called disseminated intravascular coagulation. Coagulation in the intravascular space inside the blood vessels, and it's everywhere. It's disseminated everywhere. So this is a very serious complication that can be seen in septic shock. And another complication that can be seen in septic shock is ARDS, Acute Respiratory Distress Syndrome. As you know, the lungs are highly vascularized. They have a lot of blood vessels because they need to be able to take oxygen from the atmosphere to saturate blood vessels. Now let's again return to our pathology of septic shock. This is happening everywhere, and the damaging enzymes and cytokines and different immune molecules end up damaging blood vessels in the lungs as well. And if you damage all of these blood vessels in the lungs, then oxygen won't be absorbed properly into the bloodstream. And so patients with severe septic shock end up in respiratory distress because they can no longer pull in oxygen from the environment into their bloodstream. So that's acute respiratory distress syndrome. Now a final point that I want to touch on is the cardiac output. Cardiac output will initially increase to try to compensate for this decreased vascular resistance, right? It makes sense that if you increase cardiac output, it will even out the blood pressure. However, as septic shock goes on, the heart too can become paralyzed and damaged by all these molecules, these immune molecules. So if left untreated long enough, cardiac output will start to be depressed. Cardiac output will decrease. And of course, if you decrease cardiac output instead, then blood pressure will also decrease. For symptoms, think about a very severe infection. With a severe infection, you'll see things such as fever, chills, and sweating. But a major symptom of septic shock is warm skin. As these blood vessels dilate in size, as they increase in size, this happens in all organs. And the largest organ in your body is technically the skin. So the skin takes out a lot of the blood from the rest of the body. So initially, patients will have very warm skin. However, as a patient is in shock long enough and their sympathetic nervous system tries to increase blood pressure, it's going to clamp these vessels back down to try to improve the resistance, the systemic vascular resistance, and maintain blood pressure. So with progression of septic shock, patients will eventually have cooler skin. And this is a bad sign because obviously it means septic shock has been occurring for a long period of time. And the clamping down of these blood vessels doesn't necessarily mean that fluid can't escape anymore. The blood vessels are still going to be leaky from all these vasoactive molecules that are increasing the leakiness and permeability of the blood vessel. So you'll still have this decreased tissue perfusion from all of this fluid that's accumulating in the tissues. And also, you'll see other symptoms such as respiratory distress, altered mental status, and decreased urination. As organs get starved from oxygen, they start to lose the functions they normally carry out.
Okay, let's go ahead through diagnosis. Okay, the diagnosis of sepsis is the presence of infection together with systemic manifestations of infection accompanied with an organ dysfunction. And the septic shock shows the low blood pressure that does not respond to treatment. And according to the latest diagnosis of the septic shock, it is the sepsis plus sustained low blood pressure requiring respirator to maintain the MAP higher than 65 mm mercury and blood lactate higher than 2 mm per liter. As shown in this picture, the mortality becomes very high when the patients become septic shock. We use soft score to diagnose and evaluate the severity of sepsis. This score system includes 6 systems: the respiratory, population, liver, cardiovascular, CNS, and renal. And each item can score up to 4 points according to different conditions. And the highest score is 24 points in total. Unfortunately, no one could survive with 24 points. Q-SOFA is a useful tool to detect early signs of sepsis outside intensive care settings. If a patient gets 2 points or higher, there is a high risk of developing sepsis and deserve to receive further monitoring. So it is a very useful screening tool for sepsis and should be applied in clinical settings. Q-SOFA includes 3 items. The hypotension means the systolic blood pressure lower than 100 mm mercury. The altered mental status means the GCS score lower than 15. And tachypnea means respiratory rates higher than 22 per minute. Let us see a short video about the diagnosis for sepsis and septic shock according to sepsis 3 criteria.
Sepsis is a life-threatening clinical syndrome that develops when the body's response to infection injures its own tissues and organs. Clinical criteria for diagnosing sepsis were first proposed in 1991 and last updated in 2001, but a lot has happened since. So now, a task force of critical care, infectious disease, surgical and pulmonary specialists has published the 3rd international consensus definitions for sepsis and septic shock that take advantage of advances in the science of sepsis and the ability to test proposed sepsis criteria against patient outcomes using electronic health records data. The group defines sepsis as life-threatening organ dysfunction caused by a dysregulated host response to infection. In clinical terms, patients with sepsis have suspected or documented infection and an acute change in the sepsis-related organ failure assessment or SOFA score of greater than or equal to 2. The group recommends use of a bedside score, the Quick SOFA or Q-SOFA score, comprising an increased respiratory rate, alterations in cognition, and low blood pressure, to identify patients outside critical care settings with suspected infection likely to have poor outcomes typical of sepsis. Finally, they define septic shock as sepsis with abnormalities in circulatory physiology and cellular metabolism in the absence of hypovolemia, profound enough to increase mortality. The authors acknowledge that there is no reference standard for diagnosing sepsis, and that the definition of sepsis is and should remain a work in progress.
Let's go ahead to treatment and management. Critically ill patient has damages of multiple organs, so providers need to pay attention to multiple systems. There are many aspects that should not be ignored by providers, and the devil is always in the details. First, we need to identify the sepsis, monitoring lactate, rapid source identifications and control, and early antibiotics administrations, giving intravenous fluid, and early goal-directed therapy, and most importantly, support of major organ dysfunctions. First stage, identification of source includes drawing blood cultures or urine cultures, whatever most pertinent to the history of the patient when they present it. And prompt removal of drainage of the lactate sources of infection can be life-saving and imperative. Second is, source control is source management. So this means giving targeted antibiotics to your source of infection within the first hour, and then if you have any abscesses or something like that, it really needs to be drained. Pathogens and cellular debris after being treated by antimicrobials may still cause harm. And prompt removals of old endovascular glands and devices when not localizing the symptoms of signs being identified. Last is, when you also need to obtain targeted imaging when appropriate. So a patient presenting with an acute edema should get a CT to evaluate for potential abdominal process causing the sepsis. So perform CT of the chest, abdomen, and pelvis to search for a source whenever stable. Antibiotic is very important. We use broad spectrum antibiotics within the first hour following the recognition of septic shock. The combinations antimicrobial therapies is used to cover a wide range of potential causative organisms. The duration of antibiotics commonly continue for 7 to 10 days. It may be shorter or longer depending on clinical response. And the organism culture is very important. Samples should be obtained before the administration of antibiotic. First stand of resuscitation is fluid, and more fluid. Because lowest blood pressure in septic shock contributes to poor perfusion, fluid resuscitation is an initial treatment to increase blood volume. Patient demonstrating sepsis-induced hypoperfusion should be initially resuscitated with at least 30 mm per kg of intravenous crystalloids within the first 3 hours. Crystalloids such as normal saline and lactated ringer solutions are recommended as the initial fluid of choice, while the use of colloid solutions such as hydroxyethyl starch have been proved to be harmful. Once a large quantities of fluids are given, administering albumin has shown some benefit. An UGDD definition means within 6 hours of presentation to the emergency department. Intensive monitoring of specific circulatory parameters with the aggressive management of 5 key parameters to specify the target to optimize the oxygen delivery to tissues. Parameters include 1. CVP 8 to 12 mm mercury, MIP reach to 65 to 90 mm mercury, and the urine output higher than 0.5 ml per kg per hour, the HCT higher than 30%, SVO2 higher than 65%, or SDVO2 higher than 70%. Vasopressor used in the treatment of septic shock includes norepinephrine. This is the preferred vasopressor. Epinephrine may be added to norepinephrine when needed. Vasopressin can be used as an addition to norepinephrine, but not the first-line treatment. Dopamine is combined with norepinephrine in patients with low heart rate or low risk of arrhythmia. And the angiotensine tools is newly approved by FDA, but has not been approved in our domestic market. The goal of vasopressor treatment is to get an MAP of 65 mm mercury. The organ support is the advantage of our critical care providers. For the lung failure, we use mechanical ventilation for acute respiratory failure. For kidneys, we use continuous renal replacement therapy (CRT) for acute kidney injury, and we use extracorporeal membrane oxygenation (ECMO) for acute heart failure and acute respiratory failure. We use artificial extracorporeal liver support for liver failure. There are all kinds of devices for all kinds of organ failure. And then we have a short video to give you the idea of bundle of septic shock management.
The sepsis bundle has been central to the implementation of the Surviving Sepsis Campaign, SSC, from the first publication of its evidence-based guidelines more than 2 decades ago. The bundle elements were designed to be updated by new evidence and have evolved accordingly. In response to the publication of Surviving Sepsis Campaign, International Guidelines for Management of Sepsis and Septic Shock 2016, a revised Hour 1 bundle has been developed. In this update, the former 3- and 6-hour bundles have been combined into a single Hour 1 bundle, with the goal to begin resuscitation and management with treatment immediately at the bedside. While more than 1 hour may be required for resuscitation to be completed, it is recommended to begin treatment immediately rather than waiting or extending resuscitation measures over a longer period, especially in patients with hypotension. These are the elements of the updated Sepsis Hour 1 bundle. Measure lactate level. Remeasure if initial lactate is 2 millimoles per litre. Obtain blood cultures prior to administration of antibiotics. Administer broad-spectrum antibiotics. Begin rapid administration of 30 milliliters per kilogram crystalloid for hypotension or lactate equal to or greater than 4 millimoles per litre. Apply vasopressors if patient is hypotensive during or after fluid resuscitation to maintain MAP of greater than or equal to 65 millimeters Hg. This new Sepsis Hour 1 bundle, based on the 2016 guidelines, should be introduced to emergency department, floor and ICU staff as the next iteration of ever-improving tools in the care of patients with sepsis and septic shock as we all work to lessen the global burden of sepsis. For more details, read the paper and download the Hour 1 bundle.
Let's go ahead to the EPID. Septic shock is the 13th leading cause of death in US and most frequent cause of death in ICU. In worldwide incidence of more than 20 million cases a year, and 35% of septic shock cases derive from urinary tract infection, 50% from the respiratory tract, 50% from skin catheters such as IVs, and more than 30% of all cases are idiopathic in origin. And the mortality rate for sepsis is approximately 40% in adults and 25% in children. So let's get some take-home message. The definition of septic shock is the organ injury in response to infection, leading to low blood pressure and abnormal cellular metabolism. It can be caused by bacteria and affect multiple organs and incurs MODS. The pathophysiology of septic shock is an immune and coagulation response to infections, includes pro-inflammatory or anti-inflammatory process. The diagnosis of the septic shock is sepsis with low blood pressure, needing abundant fluid, resuscitation, and vasopressor to maintain the MIP higher than 65 mm mercury and lactate higher than 2 mmol per liter. The treatment of septic shock includes intravenous fluid and EGDT, early antimicrobial administrations, vasopressor, and source controlled multiple organ support. And the epidemiology of septic shock is the leading cause of death in ICUs, commonly from the urinary tract, respiratory tract, abdomen, and the skin catheter. So, because septic shock is there, we still need to do many things to conquer this difficult climax in front of us. We believe we should solve these issues one day in the future. If you have any further questions, you could contact me through my email. Thank you.